So good evening. We will start today's CGR to keep up with the time. So it gives us a great pleasure on behalf of the Department of Neurosurgery to present this CGR, which is a unique topic. It is a series about a very ultra minimally invasive technique which we have developed here at AIIMS New Delhi, and now it's being used globally. And we would like to show you our journey, our path, and the process, what it takes to develop a new technique which can go from a paper, from ethics clearance to proof of concept to its application to its paper production to its finally coming into the textbooks. So just for the knowledge of the students sitting back there, so epilepsy is a huge problem worldwide. In India itself, we are expected to have about 12 to 15 million people suffering from epilepsy, and almost 40% of them have drug resistant epilepsy, which means that they are not going to respond to any kind of medication. And normally, by the definition of drug resistant epilepsy by the International League Against Epilepsy, is defined of failure of two drugs when combined in their optimal dosage and for a duration of at least 1 year. And again, this period is not fixed. It could be much less depending upon the frequency and the seriousness of the seizures. So if you fail two drugs, the chance of the patient succeeding being seizure free with the third drug is less than 1%. And this equation doesn't change with the newer anti-epileptic drugs or the newer seizure medications. So it's very important to define and identify drug-resistant epilepsy as early as possible in the course of disease, so that it could be offered other modalities of treatment like surgery. Because epilepsy is not something which is benign. It leads to loss of intelligence, and the cumulative mortality for epilepsy is 0.5% per year. So if somebody has epilepsy for 10 years, the mortality becomes about 5%. For 20 years, it becomes 10%. And this is our paper which was published in NEGM, which has more than 1,000 citations right now. So if you look at epilepsy surgery, we have to understand that it's an umbrella term. So you have various type of surgical techniques, and the objective of epilepsy surgery is to attain a seizure cure, number one, and in some cases, if not, to at least reduce the seizures significantly. So they could be classified as surgeries which achieve cure, or surgeries which may reduce the seizures very, very significantly. And you can see we have, as of today, we have multiple modalities by which we can do surgery. So fundamentally, when we do surgery, what we do is we identify abnormal networks in the brain, and we either resect that area, that is, we remove that area, or we provide a disconnection whereby we disconnect this area to rest of the brain. Now, these are the disconnective surgeries, what I have listed there. Among them, hemispherotomy stands out as one of the major surgeries, because you are actually removing or disconnecting one whole hemisphere. And it sounds, like I was sitting with ma'am was telling me that, brain is so delicate, each and every cell has an implication. So the question is, how can a patient tolerate a complete disconnection of an entire hemisphere or its removal? And as it happens, hemispherotomy is now accepted worldwide as one of the most effective epilepsy surgeries for most serious kind of drug-resistant epilepsy. So most of the children who undergo hemispherotomies have seizures as many as 100 to 200 a day. They're very sick. It's impossible to treat them with medications. And once you do surgery, they grow up normally. The power improves completely. They are only driven by a single hemisphere, but the power almost completely improves, and they lead a completely normal adult lives. Now, for those of you wondering that how can this happen, that you can remove one half of the hemisphere, yet the patient can go ahead to have a complete, almost near normal life, is because of the plasticity of the brain. So whenever we have when we have epilepsy, you have particularly a hemispheric pathology. So the brain becomes so damaged that slowly there is a shift of all the functions to the opposite hemisphere. So what you are essentially removing is not the normal hemisphere, but the abnormal hemisphere. And by doing so, now you are allowing the remaining normal brain to function. And this was a very well cited global study in which our institute department also had, both neurology and neurosurgery also had participated. So let me start with this story. So it's a story of this small girl from a very small tribal village from Kerala. So she had seizures. She was tracheostomized. She it's too much of noise outside. So this child had seizure onset at 9 months of age. It progressed to 4 to 5 seizures a day. Was tracheostomized, went into status epilepticus, one had to stay almost for a month. Then was referred from this village to Sri Chitra Tirunal Institute of Medical Sciences, underwent a full neurology evaluation as well as a cardiology evaluation, was advised a cardiac transplant, and then referred finally to AIIMS. So she made a journey from this small village called Karimanur and finally to Sri Chitra, and then somehow she managed to come to Delhi. She was working as some class 4 worker in the CM's office, so she managed to get some fund there. Of course, she's not very well off, or she doesn't have any kind of connections. It was just through the determination of the mother. And then finally she came to us, and then we started evaluating her. Now we found that she had an hemispheric pathology. She needed a hemispherotomy. But the question is, she was given an ultra high risk for open surgery, including death on table. So the question is, how do we treat this patient? She has a serious cardiac anomaly, has to undergo a hemispherotomy, and if we do, there is a very high risk of death on the table, and definitely not an open surgery. So the challenge was, what should we do next? So with this, I will go upon to briefly show you what is the history of development of hemispherotomy. So these sentences were compiled by my colleague Dr. Ramesh. I don't know from where he got it. So he says, if neurosurgery were the Olympic Games, hemispherotomy would be considered the marathon, and we will soon see why it is so. And it gives me a sense of pride that we have had a very comprehensive epilepsy surgery team. Since past 25 years, we have treated more than 4,500 cases. Now this happens to be one of the most globally recognized centers for epilepsy surgery, and we have very senior people sitting here who've been part of this team. Professor Bal, Professor MC Sharma, and Ajay is of course from neuroradiology, Madhvi here, Manjari of course is a neurologist, and we have Jasmine, and then we have Ramesh. Did I forget something? Dr. Ashima, absolutely. Is she here? No, she's not here. So what is hemispherotomy? Hemispherotomy is when you do surgery like this. This is what is actually being practiced in a lot of centers. So where you remove one half of the brain. You do a large craniotomy and remove one other half of the brain, and surprisingly these patients do well, but you have to understand that this is a procedure which is done usually for kids who are about 5, 6, 7 years of age. So by the time you reach 9 years, you're already pushing to the other side. The only hemispherotomies which we do in adult is post-infarct, when they have a large. Otherwise, it's primarily a procedure for young kids. And that is where we need to preserve a lot of blood. We need to prevent complications like hypothermia. And that's where the minimally invasive techniques come into being most important. And it has evolved to a technique of hemispheric disconnection, which is called as functional hemispherotomy. This, of course, is a technique of endoscopic hemispherotomy, which we again developed in this center itself. And again, it's been very widely published globally. And you can see that what we are doing is we are providing a disconnection. So the hemisphere very much continues to get its blood supply, but its neuronal connections are no more connected to the normal hemisphere. So you are providing effectively the same thing, same kind of treatment as this, but through a much more minimally invasive. And the way, we explain to patients' relatives while doing this procedure is we say that if you have a switch box which is spoiled, you can either pluck it out from the wall, damaging the wall, or you can very neatly cut the wires. So we always prefer to cut the wires. So let me show you how this technique evolved. So it started from a concept in 350 BC where Aristotle thought that you cannot have an empty space in the body. So this he did, he saw that there were no empty spaces in the body. So he says that if you have an empty space, the person is not going to survive. And in 1888, a German scientist, he performed an hemispheric resection in a dog. And he found that this dog survived. It was able to recognize, was wagging its tail, had an hemiparesis which improved very rapidly and was actually moving around. So he showed that you can remove half of the brain and the person can actually survive and still recognize people and still gain, have the same inherent personality. And then after that we come by more than 100 years to Walter Dandy, who performed this technique for glioblastoma multiforme. Until date, that happens to be the most radical procedure performed for this terrible disease. And out of the 5 cases he performed, 1 patient survived for more than 3.5 years, which is a big achievement. These patients don't survive for more than a year, but one of his patients did survive. But other patients, they had recurrence and they died. But by doing hemispherectomy, we call it hemispherectomy because your resecting was able to show that these patients have intact personalities and they were able to identify as it is so. And then they started applying hemispherectomies for epilepsies. So Mackenzie from Toronto was the first person who did hemispherectomy in 1938, about 10 years later than Walter Dandy. And then Crino from South Africa, he did a piecemeal resection. And then we had the first en-bloc hemispherectomy, started with French, followed by others. And of course, we all know Rasmussen's name, but it was started almost 20 years before by French. And then, this is a picture from JNNP which says half a brain, and this child was bilingual both in Turkish and English, and the hemiparesis is also completely improved. But this child died 10 years later from a very unique complications which happens when you do this kind of surgery, when you create a large empty space within the brain. So what is the complication that the child had? It's called as cerebral hemosiderosis, and this is uniformly fatal. So there is a progressive cognitive decline, they become bedridden, doubly incontinent, and they realized that what Aristotle has prophesied in 350 BC was actually coming true. You cannot actually leave an empty space inside the body. So then people started doing some kind of modifications. For instance, what Adams did is he plugged the foramen of Monroe, and Peacock would leave a drain from UCLA, and this is still the practice being followed in UCLA where I went there for 72 hours. And again, they would strip off the dura so as to create a large extradural space. And of course, other techniques like hemidecortication. So all these techniques developed in order to reduce the complication of cerebral hemosiderosis. And then we had development of functional hemispherotomies, where you leave the brain inside, but you disconnect it from the opposite hemisphere. So as of now, we recognize two types of functional hemispherotomies. It was earlier described by Rasmussen. And you can see this is not exactly a disconnection. So what he used to do a complete temporal lobectomy, and then he used to remove the central core, and then he used to disconnect the occipital and the frontal lobe from the opposite side. So this is not exactly a hemispherotomy, it's more like a half a hemispherectomy. Right now we follow 2 techniques. One is a vertical technique where you go from vertically and then disconnect the hemisphere. Other is you go laterally and then disconnect the hemisphere. So these are the 2 techniques which are established world over. And we have introduced the 3rd technique. Now it's done for a number of conditions. So you can do it for a post-infarct. This is more common in adults. It happens in childhood, but you can operate this in adults. But then you do it for a unique condition called Rasmussen's, Sturge-Weber, hemispheric cortical dysplasia, hemimegalencephaly. So fundamentally, you do it for techniques where you have an hemispheric pathology. And these conditions are very complex and very, very difficult to treat, particularly hemimegalencephaly, hemispheric cortical dysplasia, and even Rasmussen. So I will now request my fellow Dr. Aishwarya to show you something about clinical features. How do they present, and what are they? Because it's a very unique pathology. So you can take over.
Good evening, everyone. Myself, Dr. Aishwarya. Today, I'll be discussing about the clinical features of hemispheric disorders. So, hemispheric disorders include post-infarct gliosis, Rasmussen encephalitis, hemispheric cortical dysplasia, hemimegalencephaly, Sturge-Weber syndrome, and polymicrogyria. So, these hemispheric disorders are invariably associated with drug-resistant epilepsy. But today, let's discuss a few disease-specific features. Rasmussen encephalitis, it is a progressive disease with three disease stages. So there is a prodromal stage, which is non-specific, which has a very low seizure frequency and mild hemiplegia. And this is followed by an acute stage where there are frequent seizures, often epilepsia partialis continua, progressive hemiparesis, hemianopia, cognitive deterioration, and aphasia if it is on the dominant side. And finally, this is followed by a residual stage. And in the residual stage, there is a permanent and stable neurological deficit and continuing seizures. Coming to Sturge-Weber syndrome, Sturge-Weber syndrome is a triad of leptomeningeal angiomatosis involving the ipsilateral cortex, facial port-wine stain, ipsilateral glaucoma. So there is a classification tool which is known as a ROTCH scale. So there are three types: type 1, type 2, and type 3. Type 1, it is a classic triad which includes facial angiomatosis, leptomeningeal angiomatosis with or without ocular involvement. And in type 2, it is most frequent, which involves facial angiomatosis with or without ocular involvement, and type 3, which is the least frequent, which has only leptomeningeal angiomatosis. So this is a typical port wine stain, which is also known as nevus flammeus. So in a patient with port wine stain, the probability of developing Sturge-Weber syndrome is 7 to 28%. And historically, it was thought to follow trigeminal nerve branch distribution, but of late, it has been identified that there are certain shared progenital cells from the frontonasal placode that explains its relation with the leptomeningeal angiomatosis. We had 4 patients with cerebral hemiatrophy, of which 3 patients had Dyke-Davidoff-Mason syndrome. So this is a clinical syndrome with hemicerebral atrophy secondary to brain insult in fetal or early childhood. And these patients will have ipsilateral compensatory osseous hypertrophy with contralateral hemiparesis. Also, they will have pneumosinus dilatans, facial asymmetry, and intellectual disability. And one patient had hemiconvulsion hemiplegia epilepsy syndrome. So this is a rare pediatric epilepsy syndrome with history of prolonged focal febrile convulsive status epilepticus with unilateral hemispheric cerebral edema. And this is followed by subsequent development of hemiplegia and followed by global atrophy of the affected hemisphere, resulting in epilepsy. So 2 patients had hemimegalencephaly. So in hemimegalencephaly, 90% of the patients will have focal and generalized infantile spasms with developmental delay, with hemiparesis, with hemianopia, and macrocephaly. So there are 3 varieties. One is isolated. The second one is syndromic, if it is associated with epidermal nevus syndrome, Klippel-Trenaunay syndrome, neurofibromatosis type 1, and tuberous sclerosis. And the last one is total. Total, it is hypertrophy, but it also involves the brainstem as well as the cerebellum. Now, I would like to invite Professor Manjari Tripathi, Head Department of Neurology, to discuss about epileptic hemispheric disease and neurology EEG.
So we've seen that these are large parts of the brain, and particularly one hemisphere. However, in hemimegancephaly, you can have abnormalities in the other hemisphere, and very often this is in the form of microdysgenesis. So also in ischemic pathologies, though the insult is largely in one hemisphere, you could have the ischemic neurons occurring in the other hemisphere. Now, the typical presentation, if they come within 2 years, within a year of age, is with infantile spasms. And we all know it's a catastrophic or it's a very severe epileptic encephalopathy syndrome, where these children typically come with recurrent spasms. And these are known as either flexor spasms or extensor spasms. And the flexor ones are known as salam spells, which we used to read during MBBS from our OP Ghai textbook, etc. So basically, these children present, if they are presenting at a very young age of less than 2 years, they present with very severe generalized kind of syndrome. They'll just have a typical spasm. But sometimes you can get an asymmetric spasm. So you'll get a spasm, but one hand will go up more than the other. So you have to see from the asymmetry which side it belongs to. But otherwise, many of them, the most typical, next one. So the most typical presentation, apart from the infantile spasm, is the epilepsia partialis continua. That is, one side will have a continuous seizure-like activity and the hemisphere abnormal will be contralateral to it. They can have focal seizures, they can have tonic seizures, they can have atonic seizures, they can also have multifocal seizures and multiple seizure types, particularly when infantile spasm shifts to Lennox-Gastaut syndrome. So after the age of 2 to 3, or infantile is generally within 1 year, they go on to have multiple seizure types, which can be the tonic, focal seizures, as well as atypical absence seizures, and that becomes the Lennox-Gastaut syndrome evolution. They can have inhibitory seizures depending on the major area which is involved. So as you can see, this video is given by Dr. Jasmine. This typically in the OPD, they will come in like this. He's a little older child. So you can see the continuous seizing away of the left hand. And you can see that the right side is showing these lead-like discharges, which are phase reversing around T4, T6 and T4. So we do a clinical semiology assessment in the OPD and we then go ahead and do the EEG. Now, once it is refractory meaning they have failed 2 drugs in adequate doses and still convulsing. So it's refractory. Then they go to the epilepsy monitoring unit, and this is the patient which Dr. Chandra showed you, where the patient traveled all the way from Kerala to AIIMS for a surgery, which was very high risk, and nobody in Kerala was actually wanting to do it because of its high risk. So you can see here the kind of event she has is the eyes go to the left. So there's a recurrent drifting of the eyes to the left, and the mother notices that something is happening slowly, and she calls the staff. And the left hand moves a bit, so it's not like an EPC typically, but just the slow drifting of the eyes and a posturing with unresponsiveness. And the mother notices, again the eyes and the head go to the left. And you can see the right-sided delta ictal rhythm, which is slowing, and that's a typical seizure. So she had a right-sided lesion. So it was a focal seizure. Now here you're seeing the child engaged in some activity with the legs, and that activity halts. So there is a kind of arrest of activity, and you find eye blinking starting. So you can see in the face inset camera, the eye blinking. He looks around, and then again, the eyes are to the left here. You can see it here, and the seizure happens. So in children, you can get these very fragmented kind of seizures. You may get eye movements only. You may just get limb jerks. and then he goes into a tonic spasm. So this is not a myoclonus, it's a tonic spasm because it's prolonged. So, and he had a ictal activity from the right hemisphere. So basically what I'm saying is there can be multiple seizure types. It's impossible to show all the seizure types. Commonly infantile spasms in younger children less than a year or so, going on to West syndrome or focal seizures or epilepsia partialis continua or tonic spasms or tonic where they just fall down, multiple seizure types. And they're drug resistant. They are so severe and several in a day that these patients cannot be made to wait for a long time for the video EG. We generally fast track them into the video EG and evaluate them to lateralize their seizures and localize their seizures. Thank you.
Good evening, everyone. Today I'll be presenting the imaging part, what we usually use in the epilepsy, drug-resistant epilepsy cases. So the protocol we follow here and universally is the epilepsy protocol. It is a time effective and each sequence lasts for about 7 to 10 minutes. So we need three sequences, the T1, high resolution T1 and high resolution flare and high resolution coronal. If there are other pathologies, we use contrast and SWI. Contrast is used if there is a tumor, if you suspect a tumor or vascular malformations or infections. And susceptibility weighted image, if there is a, if we suspect any calcifications, hemorrhage, iron deposits, or if there is a venous blood. In T1, we use MP ROTCH. In this, there is a very good contrast between the gray matter and white matter. We use 1 into 1 into 1 mm cuts with no interstice gap. And in the flare images, this nullifies the CSF. So same 1 into 1 into 1 cuts we use with no interstice gap. And it is very useful if there is focal cortical dysplasia or hippocampal sclerosis, gliosis, tubers, hematomas. But this is not useful below 24 months of age due to incomplete myelination. The third which we use is the coronal T2 weighted imaging. What we do is here you can see this is the MRA. In this you can see this is the long axis of the hippocampus. This is the hippocampus. So we take perpendicular cuts in the coronal plane so that we get the detail about the hippocampus. In this perpendicular slices are taken to the hippocampal longitudinal axis and the cut size is 0.4 into 0.4 into 2 mm with no interstice gap. This appreciates the internal structure of the hippocampus. So this is the axis and we have as the my colleague had presented the cases. This is a case of pre-op MRI of Rasmussen's encephalitis. It is a type of chronic focal encephalitis. This patient presented at around 18 years of age. This patient had seizure onset around 6 months of age. They consulted at multiple hospitals. When the child was around 12 years of age, they got the baseline MRI. Here you can see the grossly you can make out the hemiatrophy. The left side is smaller compared to the right side. Here you can see the dilated sulcal spaces and the Sylvian fissure is comparatively wide open compared to the right side. These are all the features of gliosis. Over a period of time, the patient goes into gliosis. From the prodromal stage, it goes into active stage. Repeat MRI was done over next 4 years. That shows the progression of the disease. Here you can see the hyperintensity. This is the flare image. There is hyperintensity in these areas. These are the areas of active ongoing inflammation. And next stage is the permanent stage, where the patient goes into permanent deficits. In this stage, the patient presented to us that is around 18 years of age. That time the patient was planned for ROTCH, and this is the post-op MRI. Here you can see the disconnection line. This disconnection line. This one. One more pathology what we are treated is we are treated one cases of Sturge-Weber syndrome. Here, as you all know, there will be leptomeningeal angiomas and cortical and subcortical calcification. This sign what we usually have seen during MBBS days, the tram track calcification, the cortical calcification, it usually affects the posterior quadrant. This is the MRI. Because there is leptomeningeal angiomatosis, there is still the blood flow is reduced, and that goes on to the patient goes on to develop ischemia and further atrophy of the case. In this side, this is the right hemisphere appears to be of low volume compared to the left side. In the peninsular area, frontal area, parietal temporal area, you can see the volume loss. Next pathology is hemispheric polymicrogyria. This patient also presented at around 12 years of age. Patient has, in this case, there is a migration disorder. There is a arrest of the cortical neurons migrating during the neonatal, in the gestation age. Here you can see this one. Insular, compared to this side, on the left side, you can see the sulcations are very minimal. Gyrations are very minimal, and you can also see the volume loss compared to the right side. Compared to the left side, the right side there is significant volume loss, and you can see the pachygyria and multiple small cortical this one gyrations. Here also you can very much appreciate. This is a normal sulcation. There is a very less sulcation here, and you can appreciate the same thing on the T2 weighted MRI axial images also. And coming to this hemispheric focal cortical dysplasia, this is the youngest child we had operated. This child had presented at 3 months of age. This patient underwent a ROTCH at 3.5 months of age. This you can see the focal cortical dysplasia. It is involving multiple lobes. More of the, this is the cut at the level of the posterior frontal, and this is the temporoparietal area. The entire area, the right side is involved, and right side lobe is volume loss. You can make out. It's very obvious. And this is the patient sir was speaking about. This patient also had right MCA. In fact, the one which had traveled all away from the Kerala. She also had MCA. In fact, there's a T1 image, T2 image, and the CT scan. It shows the gliotic MCA territory region. In fact, this is the another case of hemimegalencephaly. This patient presented with seizures and weakness in the left side. Patient also had global developmental delay. Patient had on MRI, you could see the less developed frontal and parietal lobe, and you can also see the heterotopic gray matter, which is suggestive of dysplastic brain tissue. This patient also had a very good result. Patient underwent a right side ROTCH. So I asked for comments from Ajay sir.
Do you want to make any comments?
Imaging is critical for the evaluation and for the planning of these cases. As told that imaging protocol, we also include 2 more sequences, like we do ASL sequences to look for area of hypoperfusion, that we do. And we also do post-care T1 weighted images to look for any vessels that is helpful during surgical planning. Rest is fine. Thank you.
Good evening. I'll be presenting the functional imaging in hemispheric pathologies. Now, functional imaging over structural imaging comes into play to define 2 important things. One is the localization and lateralization of the lesion in terms of pathology, because sometimes there are bilateral pathologies also. And the other is determining the functional aspects of the other hemisphere, because that has important prognostic implications on surgical outcomes. So the 2 modalities which are used in functional imaging is single photon emission computed tomography, and the other being positron emission tomography. Now, single photon emission computed tomography basically tells us the perfusion. That is, what we are looking at when we are doing the perfusion imaging is the interictal and ictal perfusion, which determines the perfusion in the brain. And when we are looking at PET, we are looking at the metabolism in the interictal state usually, and we can also do receptor-based studies targeting various receptor-based pathways in the brain. The tracer we are using for perfusion spec is technetium 99M ethyl cystine dimer. This is basically a lipophilic tracer which crosses the blood-brain barrier and undergoes a de-esterification and is retained in the brain. The beauty of the tracer is that it provides a snapshot of perfusion at the time of injection, and therefore is injected when the patient is having the seizure, and it is the only modality which is going to show you the ictal onset zone in vivo. But the limitation of this tracer is that it has to be given timely, and the ideal time of injection is within 10 to 20 seconds of seizure onset, and therefore the injection is done in the epilepsy monitoring unit. You would have seen that video which ma'am showed. The technician was injecting the tracer as soon as they said that the seizure is starting. The technician injected the tracer into the patient who has an IV access line. So therefore, the success of an ictal spec depends on a timely injection, and therefore that is one of the major limitations. So what we basically see in these studies is interictal hypoperfusion. They are done both in the ictal state as well as in the interictal state. And what we find in the interictal state is hypoperfusion, which translates into hyperperfusion in the ictal state. Again, in the coronal slices, hypoperfusion in the left temporal lobe with ictal hyperperfusion. And these can be interpreted not only using visual interpretation, but you can also use various software-based techniques of image subtraction, wherein you subtract the ictal spec and then you co-register it onto the spec of the patient or the MRI of the patient. So showing you an objective hyperperfusion, which can be very well appreciated to the visual eye. And therefore, this is how the ictal studies are interpreted. Now, when it comes to positron emission tomography, what we are targeting is the metabolic pathway. The most commonly used tracer is F18 fluorodeoxyglucose, which is a marker of glucose metabolism and largely represents neuronal and synaptic activity. This study is usually done in the interictal state, and that is because the tracer, once the tracer is injected, there is an uptake phase of 45 minutes. And therefore, you can see practically the ictal study is not going to be possible. But when the patient has epilepsia partialis continua, as is common in hemispheric pathologies, you may have an ictal PET also. So this is a case of a hemispheric pathology. You can appreciate the interictal hypometabolism. And in this case, the cis-cos or the ictal interictal spec actually localized the onsets to the other hemisphere, which was probably because the tracer had a delayed injection and there was a very fast propagation of seizure onto the next hemisphere. So this is the case of Rasmussen's encephalitis, where you can see this is an ictal study. So what we are finding is ictal hypermetabolism. It is an ictal PET, and that is localizing to the right frontal lobe. Similarly, the cis-cos also localizing to the right frontal lobe, while the MRI is showing you atrophy of the similar cortices. Another patient with a hemispheric pathology showing ictal onsets to the right frontotemporal lobe, and this patient was also taken up for hemisperotomy with good outcomes. Therefore, the practical utility of functional imaging over structural would be for localization and lateralization of seizure onsets, as well as determining the functionality of the other hemisphere. Dr. Ramesh.
Thank you, Dr. Madhvi. Very good evening to everyone, and also happy Makar Sankranti to everyone. So, Dr. Chandra already has given the overview and then evolution of hemisperotomy from open to minimally invasive like endoscopic, and now we have progressed on to micro-invasive surgery, where you just have to drill holes and then burn and do the lesioning, which is called as ROTCH. So it was basically the introduction of robot. Neurosurgery was one of the first specialties which actually took up robots. That is an industrial robot called Puma 200, which was introduced, and it was used for biopsying a brainstem lesion. Following which, actually the other specialties took over, and then they have progressed faster, like urology and others, and they have a good system developed because of the space constraints in neurosurgery. The robotics has been just constrained to being a stereotactic guide. So based on the principles of, like we all know that we use frame-based stereotaxy for performing biopsies and everything in the deep brain lesions. So this is based on the same principle, but without using a frame. So robot is a frameless stereotaxy. Advantage is it's been proven beyond doubt with many studies that it is equivalent in efficacy compared to the frameless. Like robotic is also equivalent to the frame-based surgeries. So at AIIMS, we have been performing this robotic guided surgery since 2014 because we acquired India's first robot at AIIMS, and then we have been performing all the deep-seated lesion ablations using robotic guidance, especially the hypothalamic hematomas. So overall, our epilepsy surgery the robot has become an integral part of our surgery. SEG placement for MR-negative epilepsies, then RF lesioning for other nodular heterotopias. Endoscopic hemisperotomies, again, Dr. Chandra had pioneered, and then corpus callosatomies and multilobar dissections, which we have been using robot as a holder. Although we only perform the surgeries, but it gives a good it acts as a good assistant. And ROTCH is the latest technique which we have developed. So it's basically a disconnection procedure that technically it remains the same, and but only thing is that it is less invasive compared to the other surgeries like open or endoscopic. There is no almost nil blood loss. That's why it's called as bloodless surgery. And it's best suited for children. Obviously, they have a less blood reserve, and then we can actually do good job in these patients. The youngest patient which we operated was 5 months old. This is a basic OR setup where we use the robot. You can see the robot ROSA, which is the latest one which we are using. And the OARM we initially used to use in our cases, but now we have stopped because the accuracy is quite okay for us. So we don't use to confirm anymore. And the trajectories for the surgery, when we plan for a hemispheric disconnection, we plan the trajectories well before the day of surgery, usually a couple of days before. And I'll be showing the planning. These are the equipments which we use. So you can see here, so this is a drill bit which we use. Mainly the drill bit, which is a 2.5 mm drill hole, which we drill into the skull, and then we use the lesioning probes, which are here. So these are the lesioning probes, which are again 2.2 millimeters in diameter. And then using this handgun, we make the drill holes and then perform the lesioning. So this is again the OR setup where we have already placed the probe inside the skull. The trajectories, which as I already mentioned, that we already would have planned this well before the day of surgery. And this is a pulse generator where we use a temperature of around 74 to 75 degrees for 60 seconds. In the initial cases, we used to do it for 60 seconds. Now we are with our experience, and then we are discussing our meetings as well. And then we have come down to 40 seconds now, so that our time of surgery, which initially used to take around 6 to 8 hours, now has reduced to around 4 to 5 hours. So that's a significant reduction in time, and because they have to be under general incision, that is a very good results we have seen. So the basic steps of hemispherotomy remains the same, whether it is open, whether it is endoscopic, or it is ROTCH. So these are they are grouped into 4 groups. Like first, the corpus callosum is disconnected, following which frontobasal disconnection is done, and then the lateral disconnection, which goes along the thalamus. That is, it's a perithalamic, lateral to the thalamus. So that is the perithalamic disconnection. The remaining temporal stem and amygdala along with hippocampal resection is performed, and then the posterior disconnection, which is finally cuts the temporal efferents through the fornix. So column of fornix is cut. So these are the basic steps which are involved in any kind of hemispherotomy you perform. So this is how we do the planning, and you can see this is a robotic platform. That's a ROSA platform, and these are the trajectories. As you can see here, this case is an atrophic case. The whole hemisphere is atrophied, and then it is a post-infarct case. And that's the reason we, in the initial cases, we actually, because it was the first time we had started it, we began with this atrophic case because it will be easier for us to plan as well, and then less number of tissue to be lesioned. So in this case, we had used around 12 trajectories. So that was a minimum, and then it worked well. And following which, we moved on to do even normal and then even hemimegalencephaly as well, as you already seen the imagings. So you can see these trajectories. The corpus callosal trajectories will be 4. 4 are usually sufficient to do. This is the corpus callosal trajectories, which are like splenium, the body, we require 2, and then the anterior and the genu. And these are, as you can see here, they are spaced, well-spaced trajectories. This is for the perithalamic disconnection. In the initial cases, we used to use separate holes. So the different twistles for making different lesioning trajectories. And then with time, we moved on. We make now using a X technique, which I'll be talking to in the next slide I'll be showing. So basically, these are the sets, like the callosal disconnection, the perithalamic disconnection, then comes this amygdala and the temporal stem. So once you do this, the lesioning procedure is over. Now you can see we developed with time the X technique, where we reduced the number of holes. Initially, we used to make around 10 to 12 holes. Now we make almost around 5 holes, because we make all the perithalamic disconnection using a single hole, that is using this X technique. As you can see that they all converge at one point and then diverge again inside. The callosal trajectories cannot be used through this hole, so that we use different holes for it, because the whole callosum has to be disconnected. And you can see, I'll show you a brief video. This is how we perform it. So this is we have already planned it. And then this is a twist drill which we use to perform the drill hole. That's a 2.2 millimeter, and we are coagulating it using a monopolar coagulator. So the dura has to be coagulated before you puncture it to go inside. And the robot gives us the distance. So we can calculate the amount of distance on this radio frequency probe. Once we do that, we insert the probe to the destined target. Once it is in, we use the pulse generator. As I told, the temperature of around 75 degrees for 60 seconds. Nowadays we use around 40 seconds. Initially, we used to merge and see whether the trajectories are right. But with time, we skipped it because it used to consume a lot of time. And the accuracy was always right. So we stopped doing that, and this is how we perform the lesion. So sometimes, depending upon if it's a case, atrophic case, then we somewhere require around less than 100 lesions, like 50 to 60. If it is a normal hemisphere or a hemimegalencephaly, probably, and the highest which we have done is probably 140 lesions. It takes a lot of time because you have to keep lesioning it. And sometimes the first case which we performed, Dr. Chandra was there in the OR, and it took us 10 hours, and then we got free in the midnight. It was an initial case, but nowadays we are performing the same procedure with various modifications, as I told, the reduction in the time and everything. So our duration has come down significantly to around 4 to 5 hours maximum. So our experience with ROTCH has been 31 cases, and then we have with a mean age of around 7 years, with a mean follow-up of 1 year. So total of 31 cases, among which 8 were Rasmussen's, 4 were hemispheric cortical dysplasias, 3 glioses, 2 hemimeg. Post-infarct, we had 5, as Dr. Aishwarya had shown already. 4 of them were post-infarct, and 1 was hemorrhagic. Post-traumatic were 2, and then there was hemiatrophy with 4, Sturge-Weber 1, and then malformation of cortical development, that is a polymicrogyria, 1 case. So seizure outcome, coming to it, we had excellent outcomes. As various studies have shown, with various techniques, the outcome ranges somewhere between 50 to 90%. And with our technique, we could get ILA class 1 and 2 in 65% of the patients. If you consider 3 as a good outcome, then it will be around 84%, which is for a new technique to get into that amount of good results is nice to see for us as well. We also have had repeat surgeries in 4 of our patients, where we found that they had persistent seizures. And then when we repeated the MRI, there were some residual connections, which we actually did repeat ROTCH. And one of the patients failed thrice, so we had to convert it to an open, like endoscopic hemispherotomy, which we performed. And one of the failed older cases of endoscopic hemispherotomy, nowadays, whichever failed hemispherotomy comes, irrespective of whatever the type of surgery, we try to manage it using robotic guided coagulation. And along with that, we also have had a share of complications. We had 1 case of hydrocephalus, which required a ventriculoperitoneal shunt. There was a small bleed in one of the cases in the amygdala following, because it's a stereotactic surgery and it is a known complication. And luckily, we haven't had any major bleeding, and it was managed conservatively. The most common thing which we observe here is like delayed awakening. These patients actually, following surgery, they take around a week or so. They are drowsy. There are many reasons for that, of course, because you have there is something known as the drug hypersensitivity following surgery, because they are on benzodiazepines, they become more drowsy. But with time, it settles, and then probably most of the patients we have seen 10 days, they recover well. And only 1 case which has a major complication, which had a massive edema, and then it had to undergo decompressive craniotomy. Apart from that, rest of the cases have been fine. So, and the other thing was that in the initial cases of open hemispherotomy, which we used to do, or endoscopic hemispherotomy, we used to have a lot of patients with fever, prolonged fever. I mean, and that is not seen surprisingly in these cases, which is a good thing because probably the blood which used to go inside the ventricle used to lead to the fever, which is not there now. With this, I would like to invite Professor Chandra for concluding.
Thank you, Ramesh. Which does the mouse?
So roll. Just roll. Click on one side.
Okay. So you can see that one of the best advantages is that it's totally bloodless. You've seen in the video, for the sake of modesty, we said we lose less than 5 cc, but we don't actually lose any blood. And of course, the surgery is boring. Hemisperotomy used to be a very exciting technique. So the fellows say that now they don't see any parts of the brain. That's another disadvantage. So all you do all the time is you're just drilling holes and passing without any blood loss. The anesthetist is also not excited. So there's absolutely nothing happening. The only thing we do is drill, pass a electrode and burn it. And now, of course, you reduce the time significantly. One of the best advantages has been absolutely no fevers. So you can see right from day one, it maintains equilibrium most of the cases. Unlike endoscopic hemispherotomies or open hemispherotomies, like Ramesh was telling, there could be blood inside, which can lead. And the best part is, of course, the advantage is that it's ultra minimally invasive. So like we had this full team coming from Israel who wanted to learn this technique, and we did about 4 cases. So this is how it looks following surgery, and we just put band-aids. A few examples, for instance, this child, you can see atrophic, and now you can see this beautiful disconnection, and this is how the looks like. And this child at 3 months was completely seizure free and is walking. He had mild exaggeration of the weakness, but now totally seizure free. He used to have 30 to 40 seizures a day. Now another child was just 4 months of age, 12 to 16 seizures a day. Now you can see that this beautiful disconnection has been done without an open surgery. Another example of a 5-month-old child, again, this is the disconnection which has been done. And this child, when was referred to the GP actually called us because he says he's not understanding what surgery has been done because he doesn't find anything on the skull. So a few more examples. This is the case of a post-meningitic hemispheric damage, which again underwent ROTCH, and the child was okay, seizure free. Another case of Rasmussen. This is the post-op day 3. Now this was a child where we did a ROTCH, and he had this small connection. So obviously, we can't put the electrode here because when you put the electrode, this shifts because it's just a flap. So in this case, all we did was we introduced an endoscope and then disconnected it. So a combination of ROTCH and endoscopic allows us to take care of all these things. So our endoscopic technique had come into the textbooks. It was taken up world over. And we are very happy that ROTCH 2 has also come into textbook, and no other textbook than Jerome Engel's textbook of epilepsy, which is considered as the Bible. So those of you who want to know more about it, you can go this textbook. It is there in the library. New one, I hope the new one is there. You can go to chapter 219 and you will have a small description of the technique, what you've seen here. So concluding, it seems to be a promising technique where we have had, Ramesh, you didn't update this, but 65% have had very good outcome. And so we have not included some case which we have done recently. So we just said 31 cases. So repeat surgery can also be very easily done for skip areas, and it's quite simple. And by doing the X technique, we've been able to reduce the time by almost 50%. So within 4 or 5 hours, which is the time taken, it's actually less time taken than what is for open surgery. And there's practically nothing to be sutured. You just put a stitch. And in terms of value to the patient, it's incredible because in AIIMS, the package, it is under the Burhole package, which is 2,000 rupees. So it's about $30 US. So a technique which costs almost $500,000, they do an open hemispherotomy, you do it in John Hopkins, it costs you $500,000 US. So we are doing it in India for $30 US and a much better technique. We are doing it bloodlessly. And this is the paper. I thank all the contributors. For me, professionally, I come from an era, I've seen this hole in the brain. So first time when I went to UCLA 20 years ago, I saw, the surgeon doing this hemispherectomy. There were about 12 people standing and watching the surgery. People were clicking photographs and the whole brain was removed. And everybody were ooh-eyeing. They said, oh my God, whole brain, whole brain. And now we are happy that we have reduced that just to a line in the brain. So what happened to this child? Let's come back to this child. So we took up this child for ROTCH because that was the most minimally invasive technique. We finished about 80% of the technique when the child had a cardiac arrest on the table. So we did a CPR for almost 20-30 minutes. We were able to revive. We shifted the child to the ICU. The child was fully unconscious on inotropic support, tapered off, improved completely. And we were able to discharge, no seizures. We said, let's prepare for this CGR was supposed to be done about 2 months ago. And it got cancelled because of the strike. And at that time, we said, let us showcase this child. Let us call back the child and show that how nicely the technique has been done. And when we did a repeat MRI, we found an extradural hematoma, a subdural hematoma. So then the question is, how do we treat this? And then, of course, we referred it to Ajay, who in his expert hands, he just did a middle meningeal artery embolization. Now, this is another topic for CGR. Sometimes they should present. So you don't have to do surgeries anymore. So he just embolized the middle meningeal artery. And now, fortunately for this CGR, we have a follow-up CT scan which shows total resolution of the subdural. The child is doing very well. So this was a child who came last time when we were doing our epilepsy surgery conference. So we just had a photograph. And the mother brought some presents. So she very dutifully presented each one of us one very nice local stethoscope. He said, so she felt that perhaps she didn't know that maybe neurosurgeons don't use stethoscopes. But she did with all her sincerity. She presented the stethoscopes to all of us. So if you look at evolution, we started off with anatomical hemispherectomies. And I think we are here. But before, we start thumping our chests, I still feel that we are still grappling with our tools. I still feel we are here, we are not here. I think there is a lot of excitement still yet to come in future. So with this, we will end our CGR. Thank you very much. So any questions or any comments? Dr. Bal, you want to say something, sir? You are the senior most here in our team.
I think very excellent presentation and good case. The brain is a beautiful organ, where the metabolism and perfusion is tightly coupled with very exceptional situation like stroke. So there is logic perfusion and logic perfusion. All the time you can look at the perfusion or look at the metabolism. Then we have perfusion with the step, which is the four-man step, you can do CT. But why we do pain, why we step is very definite indication. If there is a structural reason, there is only a pain. This is why I think that there is a hypometabolism. Every brain region is hypometabolism. Region which is hypermetabolism. So that is the aspect. So the hypothesis is that when the region is in critical state, its neural of firing is less, so the blood flow is less. So when it is firing, the blood flow goes off, and then you see higher perfusion and goes stuck. Sometimes it is not, sometimes you can see the qualitatively very nice perfusion, but sometimes it doesn't happen. Most of the time it will happen in less than normal, you can not. So if you have not seen the interictal, you will always confuse that is a normal perfusion. So you have to always be state. You can interpret integral state, you cannot interpret integral state without looking. So that's the beauty. When you need a integral state, another situation, where there is a multiple lesion, you want to dissect tuberculosis. But which are people want to do? In that case, it exactly says which is the area which is firing. So that is the one definitely it is. And you have to be sometimes with the neural network, there is a much bigger region seen than what we see in the images, the structural images. In that case, if you are only limiting your vision to the say temporal lobotomy and you are left a lot of vision behind that. So you have to see a lot of utility of this. Why we use PET? PET is not very easy. You can just give the country wherever the patient is in the on drug also, computer department, you inject glucose or whatever, it takes so in a non-structural epilepsy, PET is very good to identify as certain. It's a beautiful organ, and we have a three relevant question. You know, one of the relevant questions is to understand human brain. It's for next 1,000 years to understand human brain. The other one is to understand how we from the inorganic material how life is created. You know, urea cycle. Urea is an organic or inorganic? Anybody can answer? Urea is organic or inorganic? Huh? There are neurologists who should understand it better. Urea is organic, whereas it is created from urea is not organic, is not organic, but they create organic. How do they solve? Breaking of hydrogen. It says a new creates certain condition, not from inorganic. So that is another relevant question to understand. Third, of course, very big questions to understand the universe. Out of this, medical science is given one question, that to understand the human brain. One more, working as a painter, he was solid. He was 3 months in the ICU, and after 3 months, when he gets up, he understands all the mathematics in the world. How it happens? What is happening in his brain? Suddenly he starts understanding the mathematics. He has never seen the low paid, unword, illiterate trader, and suddenly becomes the greatest mathematician. So the human brain has something. All these yogis, munis, and all these things, you read all this spiritual science, they say, you know everything, but you have forgotten. Just like in Bhagavad Gita, Arjun, Krishna told Arjun that in many years I had told this to the son told me, then the next is that and he told me. You don't even and my age, how can you do this? No, we have to go on similar. You have forgotten what I know. So the human brain has everything that you want. Any language, any science, any literature is there, but we have to understand the next 1,000 years. Also, by 1,000 years, we will understand the human brain. Thank you.
Thank you, sir. Your support has been very valuable. Ma'am, you can, I'll just put the mic. Please sit down, ma'am.
I would say, as far as the students are concerned, the younger ones are the best ones. You know, they are learning the anatomy, physiology, and everything. So your brains should be more attentive, and because you are the future researchers. Now, as far as I am concerned, you know, that very few of you might develop interest, but if you have interest, you have to pay attention. And the first thing is when you walk into a lovely research which is unique, your mobile should be surrendered outside, so that there is no disturbance at all. Now coming to as far as your talk is concerned, very nice. I look at it that some babies were 5 months old. I'm thinking of preventive, promotive, diagnostic, and therapeutic. Excellent diagnostic and therapeutic. But we need to know, is something happening in utero that these babies develop at 5 months? What is that reason? Is it that the infections that occur? I'm going to the etiological parts, because we have in the surgery or and as you have shown so beautifully, before what was the brain looking like? The first normal brain, then this, and then after the surgical treatment, you know, how much difference we made. And because of the needles that you are doing, we are doing the least injury. Now, one thing when you are doing the X, the needles are very fine. But when we put so many XX over a certain area, will it increase the trauma or not? Can we think of making it less? These are the few various thoughts. I have been marveled at a lovely talk that you've given. I wonder whether you enjoyed it or not. But I enjoyed it. And I would like the future generation to enjoy research because the institute is the place where research comes first and it comes later in any part of India. Thanks.
Thank you so much, ma'am. Just answering your questions. So the first question is something happening in utero? Definitely it is, especially in cases of hemimegalencephaly and Sturge-Weber syndrome, hemispheric cortical dysplasia. Something is happening and there's a lot of research going on. One of the interesting aspects of research which has come up recently is that cells of cortical dysplasia are very similar to the cells seen during human papilloma virus infection. So now they are trying to look at antibodies, whether you can find some antibodies against human papilloma virus. So that's one research area which is going, but there's a lot to be done in that area. And the second thing is passing just a trajectory, ma'am, it doesn't do any damage. So the damage, I mean, it's much less than what can be produced when we do a surgical access. So this is the least form of damage we can do. But of course, the future is open. We have this focused ultrasound coming. So right now the machines are not so capable. So in order to produce a single lesion, it takes 1 or 2 hours. But in future, once we combine, we will be able to produce them even without giving a skin incision. We will be able to produce lesions using focused ultrasound. Thank you, ma'am. Thank you very much.